Morning and welcome to the ENVISION webinar on MDA preparation, implementation and evaluation, lesson learned in Haiti, Benin and Burkina Faso. My name is Dr. Achille Kabore. I am a senior advisor for neglected tropical disease for the ENVISION project at RTI International, and I will be facilitating this webinar. Today, we are very happy to have Dr. Abdel Direny, Dr. Moudachirou Ibikounle, and Mr. Roland Bougma as our speakers. We hope you find the presentation useful in your work to control and eliminate NTDs. For those of you new to webinars, some operational guidance is provided in the top right corner of your screen. You should be receiving your audio through your computer. If this is not working, you can connect through a phone landline. The phone number to dial is in the webinar invite. If you have any difficulties, please type your problem into the chat box and we will try to help you resolve it. At any time during the webinar, if you have questions for any of our presenters, please feel free to type them into the chat box and we'll do our best to address them in the time we have. The slides and the recording of this webinar will be available on the ENVISION website and we will receive a link to them in an email following the webinar today. We would like to ask that you take a couple of minutes to complete a short evaluation of at the end of the webinar, and we will provide a link to this on the final slide. Your feedback is very important to us so that we can make sure we are addressing the topics that are useful to you and on your daily work in NTD control and elimination. Finally, if you find this webinar beneficial, you can find our previous webinars on our website, including one on assessing MDA coverage and another one on completing the WHO joint application package for NTDs. Let me give you a very brief overview of the ENVISION project. ENVISION is an 8-year project funded by USAID, U.S. Agency for International Development. We work in partnership with national neglected tropical disease control programs for the control and the elimination of lymphatic filariasis, onchocerciasis, schistosomiasis, soil-transmitted ailments, and trachoma. ENVISION is currently working with national NTD programs in 19 countries. For more information, please check out our website at www.ntdenvision.org or follow us on Twitter at RTI Fights NTDs. Our first speaker is Dr. Abdel Direny. Dr. Abdel is an NTD technical advisor for ENVISION. He has recently been a fellow at Emory University School of Public Health and previously worked at IMA World Health, where he was the country director for the Haiti NTD program. He helps the national program there reach 100% scale up and begin the transition from MDA to measuring the impact and starting the surveillance. Our next speakers will be Dr. Moudachirou Ibikounle. Dr. Moudachirou studied at the Center of Tropical Biology and Ecology at the University of Perpignan in France. The center is a WHO collaborating center for malacology. He is a biologist and holds a PhD in parasitology. He is currently a lecturer and the head of the parasitology department at the University of Abomey in Benin. He has served as an expert to the Institute of Research and Development in France on STH and schisto epidemiology and vector control. Since 2014, he has worked as an RTI consultant to assist Benin's Ministry of Health with STA schistomapping, coverage surveys, LF transmission assessment. His presentation will be given by Dr. Jean-Jacques Tougoue from ENVISION RTI, though Dr. Ibikounle has joined this webinar to take your questions. Our last speaker will be Mr. Roland Bougma, who is a health technician specialized in public health with 13 years of experience supporting lymphatic filariasis elimination in Burkina Faso. He is the LF focal person for the national NTD program in Burkina Faso. Since 2007, he has provided technical assistance for LF mapping, MDA implementation, transmission assessment, and other surveys throughout the African region. His presentation will be given by Mr. Daniel Cohn from ENVISION RTI, though Dr. Bougma has joined this webinar to take your questions. So, having such experienced speakers with us, we have a very interesting webinar today. First, Dr. Direny will share the AD experience conducting transmission assessment surveys. Next, Dr. Tougoue will present on behalf of Dr. Ibikounle on Benin experience assessing the effectiveness of health communication tools to educate communities about NTDs. Finally, Daniel Cohn will present on behalf of Mr. Bougma on Burkina's experience assessing and improving LF MDA coverage. At the end of the free presentation, we will take time to answer your questions and get your feedback before closing the webinar. However, we welcome you to type questions into the chat box anytime they arise during the webinar. When typing your question, please write your name and the presenter or country who the question is for. So let's get started, and I will now pass it over to Dr. Direny to begin.
Thanks, Achille, for the introduction. Good morning, everybody. I am Abdel Direny, NTD Technical Advisor at RTI ENVISION. I have the honor to share in this ENVISION NTD webinar the Haiti's experiences on tasks, and also based on our experiences to respond to the question, do we always need 5 rounds of mass drug administration? Next. The success of the Haiti NTD program is somehow due to the collaboration and communication among partners. This avoids duplication, and the most important thing to relate in the Haiti context is that donor used to take over from another in case of lack of funding. This slide shows where each donor is supported. In white, the area supported by University of Notre Dame, and yellow, the area supported by jointly by CDC and UND, and in light brown, the largest part of the country, areas supported by USAID. Next. Haiti is one of the 4 countries in the America where LF is still endemic. The Haiti NTD program was started with the LF mapping conducted in 1999-2000. The communes were categorized according to the endemicity level into high endemic or red zone, having a prevalence greater than or equal than 10%, moderate endemic or blue zone, having a prevalence between 5 and 9.9%, low endemic or green zone with a prevalence between 0.1 and 4.9%, and non-endemic or white, having a prevalence equal to 0. Note that in Haiti, the vector is Cohn fasciatus and the parasite is Wuchereria bankovstai. Next. Haiti was started MDA in 2000, prioritizing the high and moderate endemic communes. MDA should be implemented annually for at least 5 years, which is generally considered to be the reproductive lifespan of the adult filarial worms and humans and an infected human host. 2 filaricidal medicines, albendazole and diethylcarbamazine, are delivered once early to the eligible population. Treatment is directed observed. An interruption and funding at the end of 2005 paralyzed the program. New donors, USAID, CDC, UND, supported the national program in 2008 to scale up MDA and achieve full geographical coverage, reaching more than 8.7 million people in 2012. Next. Even if it's optional, the national program conducted midterm evaluation to evaluate the impact of MDA on LF and STH transmission. Midterm evaluation was conducted after the 3rd round of MDA in high endemic communes and communes with low coverage. This graph shows in purple the baseline data and orange the midterm evaluation data. We observe a significant reduction in the high endemic communes, but they are not reached zero. But for the moderate and low endemic communes, they reach zero after 3 rounds of MDA. Decision has been made to continue MDA for 2 more rounds, no matter what the midterm result, to follow the WHO guidelines. Next. After the 5th round of MDA, the program conducted a pre-task. Sentinel and spot check sites were selected based on their prevalence during mapping. All high endemic commune was a Sentinel site. The spot checks were selected amongst the blue zones and light blue zones. The pre-task revealed that all the communes with 0 ICT positive and midterm evaluation and the low and moderate endemic communes are eligible for TAS. 2 out of 3 communes with high prevalence and midterm evaluation are not eligible for TAS. And after this result, the TAS eligibility forms were filled and sent to the RPRG for approval for the commune which had an NTD anemia less than 2%, at least 5 rounds of MDA, and having an epi coverage greater or equal to 65%. And MDA was continued and the communes which fell with us. Next. Last year, the Haiti NTD program conducted TAS and 14 evaluation units, which grouped 49 implementation units. The type of survey was a school-based survey targeting 6-7 years old school children. The target sample size and the critical cutoff were determined by the Sample Survey Builder or SSB. Next. The TAS result revealed 11 out of 14 evaluation units pass TAS. MDA is top in this evaluation unit. All the moderate and low endemic communes, they pass TAS. The 2 evaluation units which failed TAS, they were highly endemic. Next. When we compare 2 indicators, median of ICT baseline and EPI treatment coverage for the evaluation unit which fell and passed us, we realized that the evaluation unit which passed us had a median ICT baseline equal to 10.5. The ones who failed us had a median ICT baseline equal to 32. But in terms of EPI treatment coverage, there was no difference among the evaluation units. Next. Now, when it comes to response to the question, should it always 5 rounds of MDA? I want to respond this question by a yes or no, but if we take a closer look and this slide, I show it earlier for the midterm evaluation, we can say that 5 rounds of MDA or more are needed for the 3 high endemic communes shown on the left side of the graph, but not always for the moderate and low endemic communes, because when we look at the moderate and low endemic communes and the graph, they were already reached 0 after 3 rounds of MDA. Next. From our experiences in Haiti, we can conclude that in low prevalence communes, 2 more rounds of MDA have been done in spite of the midterm evaluation revealed 0 prevalence, because the program wanted to follow the current WHO guidelines. And most high prevalence communes, 5 rounds of MDA and maybe more are required. However, some considerations must be taken into account when we are thinking about 5 or less rounds of MDA. First consideration is about the risk of recrudescence if MDA is stopped too early. Second consideration is the need for a 5 rounds of MDA depend to the baseline data and the status of surrounded areas of the implementation unit, because a high endemic implementation unit surrounded by low endemic implementation unit may need 5 rounds of MDA. A low endemic implementation unit surrounded by high endemic implementation unit may need 5 or more rounds of MDA because of the migration. Third consideration to respond to the question if 5 rounds of MDA is needed is what is the wash access and vector control in the country at the global level or the departmental or communal level. Fourth consideration is about the post-treatment and cross-border surveillance. Will we decide to stop MDA if none of them is in place to detect recrudescence? And finally, with limited financial and human resources, should we continue advocating for funds for area with 0 ICD positive and midterm evaluation? If we take in consideration the point mentioned above, we can take the best decision on if 5 rounds of MDA are always needed. Thank you.
Thank you, Dr. Direny, for this detailed and concise presentation. We will save the questions for the last, after the last presentation. So now I would like to invite Dr. Jean-Jacques to present on behalf of Dr. Ibikounle on the IEC materials, the lesson learned from Benin coverage surveys. Dr. Tougoue, the floor is yours.
Thank you, Achille, and hi to everyone. My name is Jean-Jacques Tougoue, and I'm a technical advisor with RTI ENVISION. I'm in charge of Benin, DRC, and Cameroon. I'm based in Washington. Today I will be presenting lessons learned from a coverage survey done in Benin in 2014 and 2015. More precisely about the effectiveness of health communication tools for the Benin NTD program. As Achille mentioned earlier, the author of this presentation is Dr. Moudachirou Ibikounle, with whom we have been working in Benin. He did this presentation yesterday in French, and today I'm pleased to do it in English. Next. Benin is a country of Western Africa. It's bordered to the northwest by Burkina Faso, to the east by Nigeria, the total population is more than 10 million of people. The country is divided into 77 communes or health districts, which is the implementation unit for NTDs activity. NTD, none has public health problem, and since 2013, the ENVISION project funded by USAID has been providing technical and financial support to the national program. Next. This picture from Benin shows an educational activity ahead of school-based MDA. The teacher interacts here with his student about STH and schistosomiasis. He basically talks about the disease, the mode of transmission, prevention, and the drugs that will be taken in class for mass drug administration. Next. This is a quick snapshot of diseases targeted by ENVISION project in Benin. As of today, 4 of the 5 diseases have started MDA. ONCO taking most of the activities with 51 endemic communes, targeting almost 6.5 million of people, followed by LF, targeting almost 3 million of people. Trachoma MDA is set to start this year. For schistosomiasis and soil-transmitted ehrlichiosis, treatment targets only school-aged children. Frequencies of treatment in targeted commune is annual, biannual, or triennial, depending on the distribution of the disease. For this fiscal year 16, more than 2.3 million people, school-age children will be treated for STH, and almost the same number will be treated for schistosomiasis. Next. This study has had 2 objectives: assessing the population knowledge about NTD and evaluating the effectiveness of health strategy and tools used by the national program. So in 2014, LF and ONCO material were assessed during the post-MDA coverage survey, and the SCH schisto material were assessed in 2015 during the post-MDA coverage survey of school-based MDA. For each of the survey, 10 communes were purposely selected, and within each community, households were randomly selected. So we had 605 respondents in 2014 and 1,038 in 2015. Next. Has method, a method for this survey, a questionnaire for this survey was developed, and is include all the following components: the channel through which information on MDA is used to reach households, understanding image and messages displayed on posters and flyers, the knowledge about NTD and clinical manifestation, knowledge about the transmission, knowledge about the prevention, and suggestion about how to improve the existing IC material. Next. This photograph is from Benin. On A, you can see on in-class training session, surveyors are trained about the survey methodology and also about the data collection procedures. In B, this is a woman being interviewed at the head of household, and in C, the man is the head of household. Next. This slide puts side by side some information from the 2 surveys. The sample size of participants to the survey were a lot higher in 2015 with 1,038 participants and 605 in 2014. The survey took place in 10 communes. Each of these communes were different during the 2 surveys, and participation of male or female were almost the same during the 2 surveys. There were no big differences regarding the two categories of level of education, and the observed coverage were 62.75 and 71.30 respectively in common survey for ONCO LF and those survey for STH and Schisto. Next. Here are the first results. So regarding the knowledge of clinical signs of each of the 4 diseases by the population, this shows that a large proportion of people were very aware of the main clinical sign of LF, meaning the big foot, with more than 80%, followed by the onco, schisto, and then STH. In other words, 80.7% of respondents said that LF is caused by LF cause elephantiasis or Bigfoot. 69% link blindness to onco. 55% of respondents identify blood in urine as a sign of schistosomiasis, but 88% of respondents of response regarding clinical signs of STH were not applicable to the disease. Next. This is with regard to the transmission mode. This was well known for onco with 32% of respondents, knowing that onco is contacted when people go to backwater and river. 20% be more specific, saying that the disease results from an insect bite. 30% were able to identify mosquito as responsible for LF. For STH, less than 40%. Almost 80% of participants had answered that were not applicable, but 14% not a correlation between non-compliance with food and hygiene rule with STH. For schistosomiasis, less than 2% of people interviewed were able to give a right answer. Next. For the knowledge about the treatment and prevention, participants have more appropriate response when it comes to LF and onco. For onco, 29% of people know that participation to MDA is a way to prevent the disease versus 35% for LF. As for the STH, only 16% of people say that observe food hygiene rule is the way to prevent the disease. Same proportion of people mention that avoiding swimming in water bodies is a method to prevent STH. Next. The survey also assessed the effectiveness of the 8 principal MDA information channels for all the disease targeted in Benin. So results showed that for onco LF, using town crier is by far the most effective way to reach the populations, followed by local community radios. Annonces via school, health center, and local radio are effective for school-based MDA. And we also found that flyer and poster were the least effective way to reach the population for all the diseases. Next. The surveys also sought information on how to improve the IEC strategy and tools. More than 80% of participants suggested that MDA messages should be broadcasted by church, via church, mosque, and other places of worship. 68% of participants contended that MDA messages via local radio should be increased. Other recommendation includes organization of focus group in villages, more involvement of local authorities. It was also recommended to review the existing IEC material being used in country. Next. So in conclusion, from this study, we can say that town crier and local radio are the most effective health education channels for NTD activities in Benin, and that effort should be made for a bigger involvement of religious leaders through churches, mosques, and when it comes to social mobilization and NTD prevention. And you can see the next step in Benin should be a study to understand cross-border issues in some health district bordering the two main neighboring neighbors, meaning Nigeria and Burkina Faso. Next. We'd like here to express our acknowledgement to the Benin Ministry of Health, to RTI through ENVISION project, and to USAID, the funding partner. Thank you.
Thank you very much, Dr. Jean-Jacques and Dr. Ibikounle, for sharing this interesting experience from Benin. I would like to remind people to please type their question into the question box, and these questions will be responded later. Last but not least, Dr. Bougma's presentation will be presented by Daniel from ENVISION. Dr. Bougma is online and he will be able to answer any question later. So Dr. Daniel, please.
Thank you, Dr. Kabore. My name is Daniel Cohn. I am an NTD technical advisor with ENVISION and RTI International based in the United States. I am very pleased to give this presentation on behalf of Mr. Roland Bougma, who is lymphatic filariasis focal point for Burkina Faso's national NTD program. Title of the presentation is Experience Implementing MDA for Lymphatic Filariasis in Burkina Faso. Slide. Burkina Faso is located in West Africa with an area of 274,000 square kilometers and a total population of 18,450,494 people. The country is divided into 13 regions and, since 2007, 70 health districts. The PCT NTDs targeted by the National NTD program are LF, onchocerciasis, schistosomiasis, trachoma, and soil-transmitted helminths. Next. Burkina Faso adopted the World Health Assembly's Resolution 5029 for elimination of LF by 2020. Burkina conducted mapping for LF in 2000 using ICT cards. The mapping found that all of the country's districts are endemic for LF, as shown to the right. Baseline prevalence was high, ranging between 2% and 74%. In the map to the left, the large red dots represent district-level prevalence of 10% or higher. You can see that almost all of the districts were at least 10%. Baseline sentinel site surveys with nocturnal microfilaremia were conducted after the mapping, with the highest registering 24% MF. MDA then started in 2001, progressively scaling up and reaching full scale in 2005. Next. Before the MDA, steps followed by the national program include mobilizing supplies, developing operating procedures or guidance for implementers, cascade training of implementers, which takes place in two parts. First, integrated training sessions for the regional and district levels covering LF, schistosomiasis, and trachoma, and second, training of community distributors before each MDA. The village-level distributors training is separated out into LF, schisto, and trachoma shortly before the beginning of each. Next. The National NTD program uses multiple distribution strategies in MDA for LF, including, in rural areas, door-to-door, and to avoid missing anyone, field-to-field distribution. In urban areas, door-to-door distribution, and also visits to places of employment. Fixed point distribution in health facilities, and reaching specific groups such as children in school. The program also reaches students in universities, military personnel in their camps outside the city with distribution conducted by the military's health service, and prisoners in prisons. In urban areas, the program uses nurses and other paramedical workers as distributors. Next. During the MDA campaign, the implementers follow the operating procedures. The different levels of the health system provide cascade supervision. The nurses monitor treatment results on a daily basis in the health posts. The distributors conduct mop-up treatment in the villages that don't reach the expected minimum coverage of 75% epidemiological coverage. Eligible persons take the drugs under the supervision of the distributors. It should be noted that this is partially applied, as not everyone agrees to do this. Some prefer to take the drugs home if they haven't eaten, for example. And finally, the program locates and treats the positive cases identified through the Sentinel and Spot Check sites. Slide. All regions and districts hold an advocacy meeting before MDA. The National NTD program holds an MDA campaign launch ceremony. Social mobilization continues to take place during the MDA campaign, with broadcast messages via radio and TV at all levels, public criers in villages and towns, and the production and distribution of posters and flyers. The program particularly focuses on villages with low epidemiological coverage, screening films there on topics such as LF case management and lymphedema. Slide. The flow of data from the village to the central level is shown on the right. Burkina Faso uses data from its national census. Epidemiological coverage is calculated for each village. The persons who decline treatment are monitored, and reported coverage is confirmed through coverage surveys. Adverse events are monitored and are provided the necessary services. Slide. On this slide, we see that beginning in 2006, the country has reached 80% epidemiological coverage every year. Geographic coverage scaled up gradually, and in the last couple of years, with favorable transmission assessment survey results, it has been possible to begin scaling back down. 100% of the districts requiring treatment are continuing to receive it. Slide. The pie chart shows that of the people treated in 2015, 52% were women and 48% were men, a ratio that more or less corresponds to the proportions recorded in the national census. Slide. Burkina Faso has used several different types of surveys to validate reported coverage for LF. These have included sentinel sites using the WHO protocol for LF, cluster sampling following the methodology of the expanded program on immunization, a survey conducted in 2015 comparing 3 sampling methods, EPI, probability proportional to size, and lot quality assurance sampling. This was done with the NTD Support Center in Atlanta. The program has also conducted knowledge, attitude, and practices surveys, and the assessment of the frequency of adverse events. Slide. This slide compares reported coverage with surveyed coverage in sentinel site villages conducted over the period 2005 to 2013. The blue bars show reported coverage, and the maroon bars show surveyed coverage. The survey showed that all surveyed sites indeed reached 65% epidemiological coverage, with the exception of Sampieri. In 2009, this village was below the target. Slide. Cluster sampling done at district level over the period 2003 to 2015 showed that in most districts, surveyed coverage was below reported coverage. Among those districts in which surveyed coverage was lower, 4 districts were below 65% epidemiological coverage. These are circled in red. The lowest coverage, in one district in 2005, can be attributed to rumors that circulated at the time and that were investigated. The surveys also found that 3 districts had higher coverage than reported. These are circled in green. Slide. This slide shows results from 2 CAP surveys, one conducted in urban areas in 2003. This one is represented by the blue bars, and one conducted in rural areas in 2015. This one is represented by the maroon bars. In the chart on the left, we see that the most common channels by which the urban population heard about the MDA campaign were health workers, followed by town criers. The most common channel for the rural population was town criers, with nearly twice as many selections as the second choice, health workers. Urban respondents cited radio and TV much more frequently than rural respondents. The chart on the right shows respondents' knowledge of MDA. The number of respondents answering do not know in 2015 is nearly half that of 2003, suggesting increasing familiarity with MDA over time. There is also a strong increase in citing mosquitoes as a mode of transmission of the disease. Slide. This slide shows reasons given by eligible persons, those who should have been treated, for not taking the LF MDA drugs. The most common reasons were that they were not informed, that they were absent, that the drugs were not available, or that they refused treatment. Slide. This slide compares the frequency of adverse events in the very first round of treatment conducted in 2001 and in the most recent treatment round in 2015. The decrease that's shown here is the normal progression of treatment with ivermectin and albendazole. through treatment, the side effects tend to decrease, in part thanks to the lowering of the load of parasites. Slide. Of Burkina Faso's 70 districts, 39 have been able to stop treatment. These are the ones shaded green, and 31 have treatment ongoing. These are the ones shaded in red. The highest prevalence is 3% in a single district. The other endemic districts are all between 1 and 2% prevalence. 6 districts are eligible for TAS in 2016 out of the 31. If they conduct it and they pass, 25 districts would then be under treatment. Slide. The principal challenge is MF prevalence of 1% or higher after more than 6 rounds of MDA in certain health districts. This is the case for the 31 districts that are still conducting treatment. Probable causes for this continuing prevalence include high baseline prevalence, environmental factors, entomology, social and cultural factors, non-compliance with treatment, the important migration flows in certain areas, the supervised ingestion of MDA drugs not being sufficiently followed, and insufficient information, education, and communication. Also worth noting is the treatment fatigue in some areas due to multiple MDAs. Slide. Looking forward, the National NTD program plans to continue organizing annual MDA in districts requiring treatment. It also aims to strengthen IEC, to develop complementary MDA strategies, including through an LF strategy review which is planned for August 2016, to conduct MDA data validation meetings after the campaign and possibly also a data quality assessment, to conduct stop MDA and surveillance surveys in eligible districts, and to continue implementation of passive surveillance activities. Slide. Burkina Faso's LF elimination program has certain key features, including the projection of films in villages with low coverage, daily monitoring of MDA data at health facility level, validation of reported data through surveys, and locating and treating positive cases based on information from Sentinel and spot check sites. The country has been able to stop MDA in 39 of 70 districts. In the majority of cases, reported epidemiological coverage was validated in post-MDA coverage surveys. These coverage surveys have given us the opportunity to adjust strategies, to change sensitization messages, to adapt IEC materials, and to strengthen supervision. Partner support remains essential for implementing additional strategies, for strengthening IEC and supervision, and for working with us to slowly but surely interrupt transmission of LF in Burkina Faso for good. Slide. We wish to thank all of our partners. Slide. Thank you for your attention.
Thank you, Dr. Daniel and Dr. Roland for this interesting presentation on Burkina's experience. I would like to thank all these presenters who have done a good job and going through all these elements of MDA and surveys. Let's take now some questions. I think there are a bunch of questions from Dr. Direny and a few of them also from for Dr. Jean-Jacques and Dr. Ibikounle. So the first question for Dr. Abdel is from Ernest from Ghana. Ernest is asking to know if the tasks they did in Haiti target 6 and 7 years old, irrespective of class. They are or use a proxy of classes 1 and 2. So the question is, did they respect the ranges in terms of age and classes? Dr. Abdel, do you have a response for this?
Thanks, Ernest, for the question. And the very first evaluation unit where we conducted us were focused on 1st and 2nd grade. But we realized that we had 10, 12 years old and 1st and 2nd grade. You know, in developing countries, children are going to school not always based on their age, but on when the parents can send them. So, and the next evaluation unit, we change the strategies to be focused on 6, 7 years old only, even if they are in kindergarten or VPK.
Okay. Thank you, Dr. Direny, for this clarification. The second question is this. Did the district with 0.98% at pre-TAS, did they pass the TAS?
Yeah, this district unfortunately did not pass the TAS. It is a high endemic communes with 37% at baseline. We were very happy to see it pass the pre-TAS, but we were disappointed when it reached the critical level, which indicated that it's failed TAS.
Okay, thank you. Thank you, Dr. Abdel. Dr. Jean-Jacques and Dr. Tougoue, there is a question on the MDA information channel.
Yes.
The question is, did it matter which community was involved, whether urban or rural?
Yes, thank you, Achille, and thank you for the question. And this is actually a good question, but in Benin, communes were selected purposely, taking into account some information like low coverage during the previous MDA. And most of these communes were rural. And in Benin also, we consider as urban area the two main cities, Cotonou and Porto Novo, where MDA is not taking place. But most of these communes are considered rural, and that's why you can see that local community radio and maybe town crier were very effective.
Okay, thank you, Dr. Jean-Jacques. It was clear from the presentation that some of the channels, mainly the town criers, are very effective, especially in the rural area. And as Dr. Jean-Jacques said, the urban, Cotonou and Porto Novo don't have this much MDA ongoing. So, but the assessment was clear to mention that town criers are really effective for all. So I will go to the next question that is also for Dr. Direny for Haiti. And it's about the categorization of LF into high, moderate, and low prevalence. So the question is, what informed the categorization into these prevalences?
Yeah, thanks again for the question. The categorization of the district and high, moderate, and low prevalence informed the Ministry of Health and the partners to where to start and which commune should be prioritized for intervention, even if the plan is to reach national geographic coverage. But when you already know that this commune is high endemic and this one is very low, so when you have to make a choice or where to start, obviously you will start where the commune is, where the prevalence is very high.
Okay, thank you very much. Another question for Haiti is, how many communes do you have? The two? I think the question was not clearly mentioned, but it's about the reduction of ICT, the ICT prevalence. So the question is that the reduction of ICT result significant between baseline and midterm evaluation?
Thanks again for the two questions. We have 140 communes in Haiti, and in terms of reduction during the midterm evaluation, it was very significant. And some communes, they have baseline 37, 35, or 34%. If I'm talking to my about my home country, Port-au-Prince, where baseline was 35% at the baseline, and then midterm it was just 5%. So very significant reduction during the midterm, if we compare where the baseline, what the baseline was.
Okay, thank you. Another question for you again is about the surveys. The question is, your survey showed improvement of MDA awareness via religious services. Are any of these religious leaders given training on how to promote MDA? And how often is monitoring locally used by government health workers to see that the information provided by religious leaders is up to date and accurate?
Okay, thanks again for the question. Very good question. The religious leaders, they are involved in the MDA as everybody, and they are not really responsible to educate the population. So the type of collaboration that the program has these with these the religious leader is that they are giving the community leaders who is responsible for education, they are giving them the opportunity or the privilege to get in the churches and to do the job, to educate the population. And as they are doing that, they are indirectly participated in that. They are not responsible directly to do that.
Okay, thank you, Dr. Abdel. There is a question for Benin. Can you explain why using the public crier is more effective?
Yeah, as I said earlier, in communities, in remote area in Benin, town crier have a very good relationship with the population. They are well known. These are people nominated by the head of the village, and they are well understood, listening, and when they convey a message, this go through. And also the existing IC material was not really well developed, and so compared to the town crier and local radio, people prefer to get a better message through all these channels, so meaning the town crier and community radios. And the country is working to improve their IC material as well as part of recommendation from these surveys.
Okay, merci. Thank you very much, Dr. Jean-Jacques. I think it's clear now from some of the studies you have conducted in other countries that the public crier are more effective than other channels. There is a related question that somebody asked is, what is the cost of town criers as compared to radio and other mobilization channels? Which one would you say is cost effective?
Yes, this is another study, and so we are looking the way to assess which one is more is cost effective. But basically, we're going to see that town crier will cost less compared to TV, radio, and so on. So, but the problem is how to get money to the right people, and to get the people to do the job, and also to supervise and ensure that the job or what they were supposed to do have been doing correctly. So this is a kind of stuff the national program is working to see for a better assessment, cost-effective supervision, to ensure that the job is doing correctly by the right person and so on. So at this point, I would say yes, town crier were less cost-effective, more cost-effective compared to other channels.
Okay, great. Someone asked the question: what specific messages do the town criers use?
Yes, this is about the MDA date and about preventions when the MDA is taking place, what to do. The drug is available free of charge, and the disease is a problem within the community, what to do to avoid to go to the river, to ensure that if they have any problem, also a kind of information to go to the nearest health center in case of any problem after MDA, during the MDA. So they have a bunch of messages well designed by the national program and sent to the health representative so that they can use during the MDA.
Thank you, Dr. Jean-Jacques, for this clarification. To Dr. Bougma and Daniel, there is a question. What plans are in place to maintain low and no transmission in the 39 districts that have stopped MDA in Burkina Faso?
Okay, thank you, Dr. Kabore. Monsieur Bougma, je vais répéter la question en langue française. Qu'est-ce qui est prévu dans les 39 districts qui ont pu arrêter le TDM au Burkina? Qu'est-ce qui est prévu pour maintenir une transmission basse ou l'arrêt total de la transmission?
Ok, merci. Ce qui est prévu, c'est le renforcement de l'IEC pour que les gens utilisent les matériaux imprégnés d'insecticides et d'ondes sous les moustiquaires pour limiter la transmission de la maladie par le moustique. Parallèlement, nous assurons des activités de surveillance pour détecter toutes les recrudescences. Non seulement nous faisons la surveillance active avec les TAS 2 et TAS 3, mais nous mettons en place, nous avons mis en place dans ces districts-là la surveillance passive en commençant par la formation des agents de laboratoire sur le diagnostic de la LF et en mettant en place les outils et les consommables pour rechercher de façon continue dans les différents laboratoires les parasites dans les champs qui sont collectés entre 22h et 2h du matin dans les différents laboratoires pour nous permettre de détecter toute recrudescence et entreprendre toute action. Donc, pour le moment, c'est ce qui est mis en place pour le moment pour maintenir le maintien de la transmission dans les zones où le traitement est arrêté. Merci.
Ok, merci. Je vais tenter de restituer fidèlement. Some of the measures which have been put in place in those 39 districts which have been able to stop treatment are strengthening IEC, particularly to encourage the use of impregnated bed nets to limit transmission by the vector, by mosquitoes, and this is fairly well known by the population. At the same time, they've also put in place surveillance to detect any possible recrudescence. This includes conducting tests 2 and 3, but also passive surveillance, and a part of this passive surveillance mechanism has included training lab agents on the detection of LF, so when they do have a chance to have blood samples which are taken between 10 p.m. and 2 a.m., they know how to examine those for any signs of the disease.
Okay, thank you, Daniel, for this translating and making sure we had a good response to this question. We have a bunch of other questions. As I said, the presenter will be available online to respond to most of the questions after we close this webinar. I will take a last question and then we will close. This question is for Dr. Abdel. If the 5-round MDA coverage were good, but the tasks fail, what is the reason? What is to do next?
Yeah, that's another good question, and thanks for the question. I think there are several things that we you need to consider. If you have the now first thing is about the coverage. You may have good coverage reported, and when you go to your task, you realize that you failed task. And one thing you need to consider is to check if your coverage was great. And other thing that you need also to consider is about what I said in terms of the baseline, because you remember that the LF is a focal disease, so you can be maybe where the site for the pretas was selected, you didn't have anything there, and now when you have to spread the task around the district, now you find more transmission. Other thing you can check is also the tests, and when I say tests, it's about the technician, if they did the test properly, if the ICT was read and during the 10 minutes. So a lot of things that you need to consider. And there's if you fail with us, if you fail the task, there is other thing that you can do. There is the continue the MDA for 2 more rounds.
Okay, thank you, Dr. Abdel. With that, we have come to the end of the webinar. I would like to thank all the presenters, all the participants, and who are joined today. The slides and the recordings of the webinar will be available on the ENVISION website at www.ntdenvision.org, and our previous recording can also be found on the website. So I would like to remind everyone to please use the link provided on your screen and in the chat box to complete the brief evaluation of today's webinar. We really do want your feedback. So with that, we'll close this session, and thank you again for joining us today.